invitation. So we all breathe because our control of breathing system automatically tells us to take an inspiration. And we have this central pattern generator that makes us take an inspiration automatically, but also regulates whether there will be a passive expiration or an active post-inspiratory phase and an active expiration. Our respiratory center is under the cortical control, and some of us can do actually magic with the air coming out of the lungs with this cortical control of this post-inspiration. But for the rest of the talk, we're not going to talk about this. We're going to talk about critically ill patients. And starting first with the normal respiratory rate responses to changing in ventilatory demands, focusing first as examples in exercise, CO2 rebreathing, and the data we have on critically ill patients, and then the effect of medication. So let's start with exercise. This is incremental exercise. On the x-axis, CO2 production, x-axis, respiratory rate and tidal volume. So this plot is my exercise test. This is a respiratory therapist of our ICU. She runs marathons. I don't actually. And this is of a patient from the lab who has restrictive lung disease. So please note that my tidal volume with incremental exercise increased quite rapidly, plateaued towards the end, while my respiratory rate was stable, low, and started increasing, passing the respiratory rate of 30 when my tidal was above 1.5 liters. And it started increasing sharply well after halfway or more on exercise. Similar pattern in my most fit colleague, a rapid increase in tidal volume, a much slower increase in respiratory rate, only to increase fast when tidal volume did not further increase. And notice the response of the patient who could not increase the tidal volume because of the restrictive lung disease, so she had to change to increase the respiratory rate much faster and to a greater extent. Similar data were obtained a long time ago in healthy volunteers with CO2 rebreathing. So increase in CO2, and notice the change in ventilation, which is achieved by first a sharp increase in tidal volume, a much smaller increase in respiratory rate. And then when tidal volume cannot further increase, respiratory rate takes the step. This is the shape of tidal volume over respiratory rate. This is an experiment, again, about a long time ago in healthy subjects in mechanical ventilation by my mentor, Professor Georgopoulos. These healthy subjects were first made hypocapnic with pressure support, and then hypercapnic with pressure support but inspired CO2. Notice the change in effort when they become hypercapnic, but also the decrease in effort when they become hypocapnic. But also notice what happens with the respiratory rate. Increases with hypercapnia, but remains very stable during hypocapnia. And moving on to critically ill patients, we published this study some years ago. We changed the level of assist in a proportional mode, so the patients are more freely able to choose the tidal volume. With increasing assist, respiratory drive and effort decreased, but tidal volume modestly increased, but respiratory rate had a very minor change. And this is our data from the next speaker, a study on partial neuromuscular blockade, where they saw with the neuromuscular blockade was aiming to decrease patient high effort, and it actually did so, and decrease minute ventilation. Patient became slightly hypercapnic, but the respiratory rate changed from about a little less than 20 to just a little bit more than 20. So respiratory rate is not a very sensitive, doesn't really change much when we change effort. And in the study I told you before, what we saw is that values in the range of 20 to 30 are all over the place of respiratory drive and effort, muscle pressure and oops, wrong slide here. What we can say is that high respiratory rate above 30 is always associated with high drive. What we also noticed is that, and we can confirm, is that respiratory rate and effort change towards the same direction at various magnitude and not predictable, but always to the same direction. And how about dyspnea? In this experiment, healthy subjects were subjected to breathing, to incremental exercise, but also with or without increased resistance. So notice the increase in ventilation, increase in tidal volume, increase in muscle pressure. Here with the triangles are with increased resistance. Notice the small change in respiratory rate, and focus here on dyspnea. This is without resistance, this is with resistance. So notice that very low work rates, so very low respiratory rates, resistance caused the patient to suffer from severe dyspnea. So again, respiratory rate doesn't tell us anything about whether the patient is experiencing dyspnea or not. And let's see how we modify respiratory rate with the medication we give in the ICU. We know that, oops, instead of my figure, there's something else there. Oh. Opioids decrease respiratory rate more than effort, but fentanyl decreases effort more than other opioids. They say that this is likely a cause of the increased death rate that we see with illegal fentanyl use. Now, propofol decreases effort more than rate. Again, there's something wrong with my slide. This is a quite old experiment, and you can see how the tidal volume drops with propofol. Midazolam has a similarly large effect on effort, but minimal on respiratory rate, while Dex, that we're currently using more and more often, has minimal effect on drive and effort, but it may affect respiratory rate by modifying the cortical inputs, modulating respiratory rate. And this is also a common indication for the use of Dex. So my slides are really modified here.
Is that your slide? Is that the one you want?
Yes, but there's several things that are missing. Anyway, let's focus now on the potentially injurious effect of rate if respiratory rate can actually cause ventilator-induced lung injury. So first, in vitro studies, what they have shown is that changing the amplitude of deformation of cells or changing the frequency when the cells are deformated can cause cell death and increase permeability. This part that is actually better shown here shows that the change in deformation or the change in amplitude causes increase in permeability. Notice that they had to change for the same amplitude, the frequency from 25 to 1 hertz, so 4 times higher, while a 50% change in amplitude had the same increasing permeability effect. And you are all aware of the concept of mechanical power. This has been extensively discussed in this meeting. And what has been introduced several years ago is that we don't only care about how much the alveoli is deformed, but also how many times this happens over time. So respiratory rate is in the equation of power as tidal volume. Respiratory rate, the impact of respiratory rate on mechanical power is smaller than that of tidal volume. And indeed, studies analyzing data from the ARDS studies have shown that increase in driving pressure increases mortality, increases in rate also increases mortality. The effect of rate is about 4 times smaller than that of driving pressure. And because we all love applied physiology in the ICU, let's see how that implications of respiratory rate are translated in our critically ill patients. So a high respiratory rate. Let's discriminate between spontaneous and mechanical rate. We can have a high spontaneous respiratory rate when we have when our patient is experiencing pain, anxiety, delirium, And this is cortical inputs, so it's what we call load independent. If you modify the ventilator, the patient's respiratory rate is likely not going to change. Then a patient may exhibit high respiratory rate because of chemical inputs, hypoxemia, hypercapnia, acidosis, combined with inability to increase tidal volume. This is a prerequisite. This is what we call a load-dependent high respiratory rate because it will decrease if you provide further assist with the ventilation. And so mechanical respiratory rate. A high mechanical respiratory rate may be the one that we have selected in a controlled ventilation. We would have done so if the patient has high demands and high distending pressure, so low lung compliance, has forced us to use very low tidal volume and compensate with a higher respiratory rate. The mechanical respiratory rate may be high, but not because we set it to be like that, but because the patient is able to trigger the ventilator and have double triggering, or because the diaphragm contracts without the patient control of breathing saying so as a reflex in the form of reverse triggering. So a high respiratory rate is indeed associated with adverse patient outcomes. But I'd like to point out that it is not just because it may increase the risk of injury by increasing mechanical power, by increasing last stress in the form of double triggering, or by increasing dynamic hyperinflation in the case of obstructive disease, but also, and perhaps more importantly, because it is a marker of a severe derangement. The patient has to have VQ abnormalities, increased dead space, high CO2 production, low lung compliance, weak muscles, or uncontrolled pain and delirium. And I think you will agree with me that all of these factors are independent predictors of adverse outcome. So it's not surprising that a high respiratory rate has been associated with non-invasive mechanical ventilator failure and weaning failure. Some examples here from the LungSafe study: increased respiratory rate in survivors over non-survivors, increased respiratory rate in NIV failure compared to NIV success, increased respiratory rate associated with higher mortality in ARDS as mechanical power. And I'd like to, before closing, emphasize on another problem, a non-decreasing respiratory rate and how that may be injurious. Because our control of breathing system will not change the respiratory rate, will not decrease that, it will choose to decrease the magnitude of effort when assist provides adequate or excessive tidal volume. So this is my patient. I had him on pressure support of 5, increased pressure support of 15, and PDI, the amplitude of swing of PDI decreased from 12 to 30, while respiratory rate changed by 1 breath per minute. So it's easy to over-assist the patient, and the respiratory center, the respiratory rate does not protect the patient from that. That is why we can easily have also periodic breathing with excessive assist. Even healthy subjects, like in this experiment, increasing assist actually decreased the PCO2 below what is called the apneic threshold, the level of CO2 that we stopped breathing once when we are asleep or sedated. And that is how, and you all know from cardiovascular medicine that periodic breathing has important implication for the cardiovascular system. So, to conclude, respiratory rate in a capsule, absolute values are markers of drive and effort only at the extremes and nothing in between what we commonly see in the ICU patients. Respiratory rate increases when ventilatory demands increase, only when there is a limitation in tidal volume increase. It may be affected by cortical inputs to the respiratory center. It may cause lung injury, no doubt about it, but most importantly, it's a sign of severe derangement when we have critically ill patients in mechanical ventilation. And do remember that it does not decrease when ventilatory demands decrease, subjecting the patients to the risk of diaphragm atrophy because they will have to decrease their effort. With that, and on time, thank you for your attention.